everyone. My name is Simran Chowdhury, and on behalf of Voice of Healthcare, I welcome you all to all of you joining from across the country and perhaps even beyond for today's virtual panel discussion titled Understanding the Silent Decline Neurocognitive Impairment Beyond Age, with a special focus on therapeutic role of EGB 761 in the management of neurocognitive disorders, organized by Voice of Healthcare and supported by Schwabe India. This session, we aim to explore one of the most pressing and often overlooked issues in neurological and psychiatric healthcare, neurocognitive decline. While commonly associated with aging, research today paints a broader, more complex picture, one that demands proactive, multidisciplinary attention. Before we move forward, I'll just quickly give a brief how we'll be going ahead. So this session is structured into 90 minutes dialogue featuring a keynote address, a scientific presentation, an expert interaction focused on panel questions and live question answer with our audience. And now, without further ado, allow me a pleasure to introducing our eminent line of speakers joining us tonight. Our chairperson and moderator, Dr. Debashish Chowdhury, Director, Professor, and Head of Neurology at GB Pant Institute of Postgraduate Medical Education and Research Institute, New Delhi. He is a pioneering figure in the field of neurology with a special interest in neurodegenerative and cognitive disorders. Welcome to our show, sir. It's a pleasure having you.
Thank you. Just a small correction. I have just relinquished the post of HOD, so I am just a director professor of neurology at the moment.
Thank you so much for that correction, sir. Thank you. Going ahead, joining us from the international stage, where we have a keynote speaker, Dr. Martin Burkat, international expert in neuropharmacology, whose work has contributed immensely to our understanding of plant-based neurotherapeutics. Welcome to our show, sir.
Thanks for the kind invitation. Good afternoon, good evening to everyone.
Thank you so much for joining, sir. Our esteemed panel of experts, Dr. Arjun Arya, Director and Senior Consultant Psychiatrist at Arya Hospital, Neuro-Psychiatry and De-Addiction Center, Chandigarh. Welcome to our show, sir.
Yeah. Hello, everyone. Good evening.
Thank you so much for joining, sir. Dr. Debanjan Banerjee, Consultant Old Age Psychiatrist at Apollo Multispeciality Hospital, Kolkata. Welcome to our show, sir. Dr. Murli Krishna Konda, Senior Consultant Neurologist at Prandhara Super Speciality Hospital, Hyderabad. Welcome to our show, sir.
Thank you and good evening all.
Thank you so much for joining, sir. Dr. Vinay Kumar Agarwal, Senior Consultant Neurologist and Director at Pragati Hospital, Bareilly, Uttar Pradesh. Thank you so much for joining, Dr. Vinay.
Thank you very much.
Thank you so much, sir. Once again, thank you so much to all the panelists for being here with us for this important discussion and to set the stage for this important conversation. It is now my privilege to invite Dr. Debashish Chaudhury to deliver the keynote address where he will conceptualize the science, the urgency, and the therapeutic promise of addressing neurocognitive disorders beyond age. Dr. Chaudhury, over to you, and I request to take the session ahead.
Thank you. Thank you, Simran.
Thank you so much.
Welcome all for this important session, and I thank you for sparing your time today for this webinar. Now, as you all know, that globally the aging population is increasing, and of course, with age there is a normal neurocognitive decline that often is seen. Of course, that is slightly a debatable issue whether there is anything normal, but definitely the neurocognitive functioning declines over the age as we reach 70, 80, and 90s. And of course, then that is when that is afflicted by a particular disease like Alzheimer's disease, or in patients who have got multiple risk factors like multi-infarct states, or some in India, for example, in Indian setting, some infections, so then that gets accelerated and cause further cognitive decline. And that comes at a heavy price because not only these patients pose a significant burden in terms of their management, because management diagnosis is delayed often and management becomes difficult, access to healthcare becomes difficult, and also it puts a lot of pressure to the caregivers because they have to manage these patients. Unlike in the West, where we have an insurance system and structured pathways for the patient care, in India, for example, it is mostly based on at an individual level, and therefore these patients have great difficulty in accessing the proper care that is needed for their gradual neurocognitive decline. Now, having said that, the science has made great inroads in understanding that why this neurocognitive decline happens, and we have now know about the amyloid therapies, the monoclonal antibodies that has been produced to combat this, and there are drugs which have now been FDA approved. But many of these drugs are beyond the reach of the common general people. One. Secondly, they cannot be given to all patients because they have contraindications. The third thing, that they are highly priced. So therefore, there is always a need to develop some alternative medications and which are safe as well as effective, and they can have a salutary effect on the progression of these neurocognitive decline. So many plant-based therapies are, have been studied over the years, and one particular compound called ginkgo biloba that has been actually studied in very great detail. But the problem with the plant extracts is this, that you need a lot of science, a lot of pharmacology behind the extraction, the purification, and the validation of the active ingredients which are responsible for the therapeutic effect and cutting off the elements which are responsible for the adverse effects. So, the pioneering research by the Schwabe group for this compound has resulted in introduction of this molecule world over, including India. And after its introduction, what has happened is that I was a member of the DCGI, the Drug Controller General of India. So we suggested that there should be a phase 4 study to really see that how this molecule is doing good for the Indian patients. So we have undertaken a study which has been now published, and it has shown very encouraging results. So before we go into that, I would now request Dr. Martin, who is an expert, an international expert on plant-based pharmacological products, especially the ginkgo biloba products, and he is going to outline that what has been the major discoveries, major challenges, and major outcomes that has shaped the landscape of the use of ginkgo biloba for the world as well as for India. So, Dr. Martin, please. And I request all the participants to kindly pose your queries, anything you want to, ask. Feel very free to ask any question in the chat box so that we can take it up after the lecture during the discussion time. So over to you, Dr. Martin, please.
Thank you, Dr. Chowdhury. It's a privilege, it's a pleasure to be with you here today. Thank you for the invitation to give this lecture. So if Simran, if you could activate my slides, please. So I'm a physician from training. I started my professional career as a psychiatrist, treating patients with dementia, with Alzheimer's disease, with other types of dementia, before I joined the pharmaceutical industry. So it's a pleasure to be here among my colleagues, among other physicians. And I've been invited to give an overview on the clinical evidence on the ginkgo biloba special extract EGB 761 in mild cognitive impairment and mild to moderate dementia. And because it is very important to understand plant-based medicines, the pharmaceutical quality that is the basis for the clinical efficacy and safety of the product. To be honest, this is only one of the indications the product has been studied for and is approved for. It is also approved for the treatment of tinnitus of all relevant etiologies and for the treatment of vertigo of all relevant etiologies. But this would be in lectures of its own, so today I will focus on neurocognitive decline. The compound EGB761 is recommended in guidelines from many international organizations, so I am happy I'm not the only one recommending the product today. Already 25 years ago, the WHO classified the product as an anti-dementia drug. 10 years later, about 10 years later, it was recommended by the World Federation of Societies of Biological Psychiatry, equivalent to acetylcholinesterase inhibitors such as donepezil. In the following years, it was recommended by many national and international organizations, neurology or psychiatry organizations in Europe and worldwide, also in many Asian countries. And importantly, earlier this year, recommendations for EGB761 have been included into Indian guidelines. So what do the guidelines recommend? The Indian guideline from the Indian Psychiatric Society recommends the ginkgo biloba extract, but only the extract EGB761 and only at a daily dose of 240 milligram to improve cognition, to incorporate it as part of a multi-domain intervention for mild neurocognitive decline. Here in Europe, very important is the European Medicines Agency, our regulatory agency. And after reviewing all the clinical data available, it concluded that ginkgo biloba extract is a herbal medicinal product for the improvement of age-associated cognitive impairment and of quality of life in mild dementia. When it comes to dementia, I personally love the wording of the recommendation of the World Federation of Biological Psychiatry. I think it gives a very clinical-based, a very realistic view on what we currently can do pharmacologically for our patients. So it reads, for symptomatic treatment of Alzheimer's disease, donepezil, galantamine, memantine, ginkgo biloba extract, and rivastigmine show a modest, over a limited time, effect in part of the patients. And therefore, they are recommended. These recommendations certainly are based on extensive clinical research that have been analyzed in multiple meta-analysis. One of here is shown, and it very nice summarizes that in a series of large placebo-controlled trials, it has been shown for patients with mild to moderate dementia that EGB761 improves cognition. That is very important for the patient himself. It improves activities of daily living, such as caring for himself, caring for a household. This is also important for the relatives. And the effect is so strong that it can be realized by the treating physicians that give a global rating, and the global ratings from those trials also confirmed the efficacy of the compound. Does it work for every patient? There is a specific patient group we learned over the years in many trials that benefits most from the product. These are patients that have both cognitive impairment and neuropsychiatric symptoms. Here are the data from the US trial, a large US placebo-controlled US trial. And if you look at all patients included, this is the left-hand panel, there was no clear efficacy compared to placebo on cognition. But if we look specifically at patients that had both cognitive impairment and at least some neuropsychiatric symptoms, such as agitation, apathy, depression, anxiety, irritability. There was a clear advantage, a clear benefit from EGB 761, and this has been replicated in a number of follow-up clinical trials, specifically in this patient populations that have confirmed the benefit for those patients. And EGB 761 does not only improve cognition in patients with neuropsychiatric symptoms, it also improves the neuropsychiatric symptoms itself. And it does it to an extent that is noticeable by the caregivers and that alleviates the burden of the caregivers in a significant way. And as Dr. Chowdhury, our esteemed chair today, mentioned, there has been a specific trial to confirm and validate these findings in an Indian patient population. And it nicely shows that the symptomatic improvement I've shown you on cognition, activity of daily living really translates into high response rates that were rated by the treating physician. This trial was of 18 weeks duration, and you see that no improvement, no change was noted by only 20% of the patient population, and 80% of patients benefited from treatment as rated by their treating physician. These were patients with Alzheimer's disease, with cerebrovascular disease, or with mixed dementia. We have looked into the data of a number of clinical trials to see whether there is any difference in the effectiveness in Alzheimer's dementia versus vascular dementia. And as shown in this example here, a study from the Ukraine, there was absolutely no difference. So the product is effective in both types of dementia. In Asia, vascular dementia, vascular cognitive decline is particularly prevalent. So we performed a specific meta-analysis and systematic review and selected only those patients with post-stroke dementia that were included in those trials. And again, it was shown as compared to placebo that the product improves cognition, activities of daily living, and global rating. This has recently been confirmed in a randomized controlled trial conducted in China in patients with post-stroke cognitive impairment. Patients were treated quite soon after acute ischemic stroke. Within 2 weeks after acute ischemic stroke, they were treated for half a year. And as you can see in the left-hand panel, in a measure of cognitive function, the Montreal Cognitive Assessment, patients significantly improved as compared to placebo. But what is the relevance of an improvement in 1 to 2 points in MoCA? This is shown on the left-hand panel, where again the treating physician gave a global rating of the change of treatment. And you can see again that around 80% of patients improved significantly, and this rating was very different in the standard treatment group. So what I've shown you so far were symptomatic effects. Those placebo-controlled trials have been conducted for half a year to 1 year duration, and patient improved in symptoms. But what we are really concerned about in our patients are the long-term perspective and the long-term decline. So the question is, might the treatment with ginkgo biloba extract have an effect on the long-term decline of those patients? And there are some new data, real-world data from large databases consisting of electronic health records from office-based physicians from Germany. And here I'm showing you 2 of those studies. The left-hand panel is a studies in patients with mild cognitive impairment. There were 25,000 patients with mild cognitive impairment that were followed for up to 20 years within this database consisting of electronic health records. And as you can see, there was a clear, significant association between the prescription of ginkgo biloba extract by the office-based physicians to those patients and the incidence of dementia in the following years. The more often a ginkgo biloba extract was prescribed to those patients, the lower was the risk for converting into dementia at follow-up. And in the same database, there were around 5,000 patients with dementia where the physician gave a rating of dementia severity, so mild, moderate, or severe dementia. And again, these patients were followed up longitudinally in this database, and you can see that the risk for progression of dementia severity, so from mild to moderate or from moderate to severe, so the risk of progression was significantly lower in those that received ginkgo biloba prescriptions than in those that did not receive the product. Comparable signals were seen in other real-world study. So the left-hand panel is a large European, international, multi-center, non-interventional studies that followed patients that were treated with cholinesterase inhibitors for 12 months. And a subgroup of those patients also was treated with EGB761 as additional treatment. And when the investigators analyzed the change in cognition, to their surprise, to be honest, they realized that those patients that received the combination of a cholinesterase inhibitor and EGB761 had a smaller cognitive change than those patients that only received cholinesterase inhibitors. A similar finding was recently published by a neurologist from Turkey that runs a large database in a hospital outpatient memory clinic following patients for up to 10 years. And she analyzed her patients by the treatment that they received and calculated the decline with a specific statistical method. And what you can see in the right-hand panel, the upper part, so the higher the number is, the faster was the decline, and the lower the number is, the slower was the decline. And she included patients with prodromal dementia, so mild cognitive impairment, patients with Alzheimer's dementia, and patients with non-Alzheimer's dementia. And interestingly, those patients that received EGB761 as part of a combination treatment had a slower progression over time than those that did not receive EGB761. So we've seen in a number of databases now signals that EGB761 alone or in combinations with other treatment appears to delay progression of dementia. Efficacy is only one side of the coin. We physicians always are very much interested in safety and tolerability because we do not want to harm our patients. And this balance has become even more important now that the new anti-amyloid antibodies become available. So the safety and tolerability on safety of EGB761 certainly is based on a large number of placebo-controlled trials. And here we did a meta-analysis of more than 3,000 patients, more than 6,000 patients included in all those clinical trials we as Schwabe have conducted over decades. And surprisingly, none of those adverse events that it listed in the prescribing information in many countries as potential side effects was more frequent with EGB761 than with placebo. To be honest, there was no specific adverse effect of the compound detected in all of those placebo-controlled trials. So the take-home message is the product is very well tolerated. As EGB761 is a herbal product, pharmaceutical quality is the basis of everything. And we at Schwabe make major effort to ensure highest possible pharmaceutical quality of the product. Unlike synthetic compound, for example, like donepezil, that is one molecule, a herbal extract is very different. What you can see here is what we call a fingerprint. It is a chromatogram, a chemical analytic method that tries to identify all the compounds that are in the extract, and it's 80 to 100 constituents, so 80 to 100 chemically different compounds that together as a mixture make up EGB 761. So the art is to keep this mixture stable batch for batch, year after year, to ensure it is always the same. And what is obvious, if you look at this picture where you can see that the extract is a complex mixture, it obviously does not have one mode of action. Obviously, it is a multi-target mixture that has multiple mode of actions. Some of the constituents, some of those, we here have the high peaks, like the flavone glucosides or the terpene lactones, have been studied in more detail, mostly in animal experiments, and we have quite a good understanding of their modes of actions. But there are a number of other compounds in there that have hardly been studied. So we are sure we only understand part of the mode of actions of the compound. What has been studied quite well, also in man, is that the compound promotes microcirculation. The mode of action is likely related to the red blood cells, the erythrocytes. They become a bit more flexible, so they can easily pass through the capillaries to the very minor vessels, and this improves microcirculation. It is not related with any effect on blood coagulation. But it has also some different effects. It improves neuroplasticity. This has been shown in many, many animal models. And it also improves neural signal transduction, mainly as far as we understand dopaminergic neurotransmission, and dopaminergic neurotransmission in the forebrain is very important for attention, for concentration, and therefore for cognitive function. So how do we keep the product stable? How do we ensure that is always the quality is always the same? This is because like any herbal product, like any herbal extract, the active ingredient is not defined by its chemical structure. It is designed by its production process. So the production process is very complex. We have recently published it here. It's more than 20 production steps. And we keep all these production steps stable. We cannot exchange one of the machines involved. We cannot just use another supplier of ginkgo leaves. We keep everything stable. There are many, many levels of quality control. We measure everything we can measure within this process. And so we keep the product stable. Here we have analyzed batches from the product over a decade. And the green dots here is EGB 761, and the red dots are batches from ginkgo extracts from other manufacturers. And more than 20 quality control parameters were measured, and with a statistical method here concentrated to a three-dimensional diagram. And you can see the green dots really are always together. And to be honest, you cannot see most of them because they are exactly in the same place, but they are always very close together. So we really managed to keep the product stable for more than a decade for all those batches we have produced. And obviously, ginkgo biloba extracts from other manufacturers are something different. One, as Dr. Chowdhury has already mentioned, one thing that is important if you manufacture herbal products is if there are some harmful constituents in the herb. So here in the ginkgo leaf, you have to keep them out. And there is one constituent of ginkgo leaf that you do not want to give your patients. It is ginkgolic acids that might cause allergies, and we keep it very low. So the red line is what we are allowed to have, 5 parts per million, so a very, very low amount. And the blue line is what we manage to achieve batch by batch, and you can see we can keep it low, really beyond the detection of the threshold of detection for most of the batches. So we really can keep ginkgolic acid out of our product. So this stability of quality is the basis for efficacy and safety, and is the basis that what we have seen in clinical studies you can expect to see if you give the product to your patients. And the product is the best researched ginkgo biloba extract. So here is an extract from PubMed, just counting numbers of publications on the product compared to another ginkgo biloba extract, also from a German manufacturer. Lichtwehr is a manufacturer. And you can see that by large, EGB 761 is the best researched ginkgo biloba extract. So to summarize, the product is an evidence-based and well-tolerated treatment option for mild cognitive impairment and mild to moderate dementia, in cerebrovascular disease, in Alzheimer's disease, and as we know, it's often a mixture also in mixed dementia. So thank you for your attention.
Thank you. Thank you, Dr. Martin, for a very excellent lecture. And I think you have summarized all the important aspects of this drug, EGB 761, and highlighted the pros and cons, showed us the evidence, and also clearly outlined that why this product is so important, because of its highest possible standards of purification and maintaining the chain in a extremely careful manner, so that the products batches after batches meets the same efficacy and safety standards. So thank you very much. So I think I'll open up the discussion with my Indian colleagues one by one, and they might be asking you some of the questions. So I will start with Dr. Arjun Arya. Dr. Arya, what is your impression on this product, and have you used this product, and what is your clinical experience if you've used them?
First of all, Dr. Martin, it was a very informative and a very good lecture. And I've been using this product in the last 4-5 years. This product has shown promising results in neurocognitive disorders, particularly elderly, when it comes to MCI, mild cognitive impairment, and patients with Alzheimer's disease, and particularly with vascular dementia. 2 patients of chronic depression and patients with comorbid disorders with depression also I have tried, and this product has showed promising results. I would like to mention that all psychiatric disorders, they have a neurocognitive impairment, which is seen early in the course of depression, bipolar, and other psychotic disorders. The other symptoms also persist, but then symptoms like attentional impairment and executive function impairment, they do persist despite the remission. Likewise, the impairments which are seen in the memory processing and speed functions and others are also common, which are seen in the bipolar disorders and schizophrenia. So I would say that neurocognition is a very strong and a prospective determinant of functioning in all psychiatric disorders. And also people with psychiatric disorders are more vulnerable and to develop dementia and other in the elderly phase. So wherein the role of Tebokani GB71 comes into the picture. It has promising results. It's a herbal supplement, so less of side effects. I've not encountered any kind of drug interactions with other molecules, and particularly I've used it with combination with acetylcholinesterase inhibitors like donepezil, rivastigmine, as well as mementamine.
Okay, so that's good. I'll come back to you with few questions. But before that, Dr. Vinay Agarwal, I think you have used this drug for some time in your patients. So, the Alzheimer's patients or even mixed dementia patients, they have a lot of this, um, behavioral issues, right? And
Yeah.
people often ask for drugs. So, do you find that what Dr. Martin has suggested, that subset of population is getting more benefit with this drug, EGB 761, compared to the other cognitive disorder patients?
Yeah. Thanks, Dr. Debashish, for asking a very important and pertinent question. like, I have seen really a very nice results, and that too surprising in a sense. My experience has been that using it for specifically for psychobehavioral problems in patients with my MCI or early dementia, the results were very quick. Like otherwise we expect in cognitive decline that it takes few weeks to take effect and to monitor it and to find it out whether it's really working or not. As for the psychobehavioral aspect is concerned, you come to know very easily. My experience has been that works very fast in psychobehavioral problems. Really, I have a few patients in which it has worked dramatically. And if I have discussed, someone is not going to believe that it's really working. At the same time, because we know it doesn't have any significant side effect and there's no important drug interaction, so always, if a patient is having psychobehavioral symptoms, my first choice, if these symptoms are relatively my first choice, EGB 761 always, and I
Right.
am satisfied.
Right, many of these patients are also taking a lot of drugs. That's a very pertinent point because they have vascular risk factors. They might be having hypertension. They might be having coronary artery disease. So, especially they might be taking antiplatelet drugs. So, there is one concern though. People have raised that there might be some bleeding disorder associated with drugs. So, I would like you to comment and then go back to Dr. Martin. Is there any data to suggest that this is a real problem or this is not a significant problem in your experience? The interaction and causing a bleeding problem.
So this is an important question. This is one of the most frequent questions we receive, indeed, and there has been a lot of studies and there's a lot of data. And Simiran, if I could go back to my presentation, please, and we can go to the slide 28. Simiran? Yeah. Can you?
Slide 28 with the meta-analysis.
Yes, can you
that
go to
corresponds.
slide 28? That is a hidden slide. Or perhaps I can share the slide if this works better.
Dr. Martin, we have your slide still 21 only.
Okay, so I will share my slide. So is it shared now?
We can't see it. Yeah, now it's.
Okay,
Yeah.
I will.
Yes.
Now it's
Okay,
visible, yeah.
now it's visible. So what I've here are two of the major placebo-controlled trials that have been conducted with the compound. It have been dementia prevention trials, so elderly patients at risk for dementia, several thousand patients treated for 5 to 6 years. And both studies looked for bleeding, and certainly there were cases of bleeding because these were large populations of elderly patients. And you can see from both trials, left is a French trial and right is the US trial, that there was absolutely no difference in the incidence of bleedings between EGB761 and placebo.
Correct. Thanks for sharing that, Dr. Martin. And I think that that settles the issue actually, because many of the neurologist friend of mine have been asking this to me that did you see any increased bleeding risk? Anyway, we go to now Dr. Debanjan Banerjee. Debanjan, what's your take on this drug? Have you used it? And if yes, in which kind of population, which kind of patients, and what's your experience on for this drug?
Yeah, thank you so much, Dr. Chaudhary. I'm audible, right?
Yeah, yeah.
Yeah. And thanks, Dr. Martin. It was a brilliant lecture, and you highlighted many of the very pertinent aspects of clinical practice as well. Now, I'm an old age psychiatrist. I have been using this molecule for quite some time now, and I must, go in the same lines as Dr. Arya mentioned. Especially, let me start by mentioning a very grey population where there is a significant overlap between late life or geriatric depression and dementia. We often say that depression is a harbinger of cognitive decline. So, for many of these individuals, we see that the mood symptoms remit. However, there is a significant neurocognitive impairment if we assess them clinically, and that persists for quite some time. Many times they may not reach the clinical cutoff for dementia, but definitely it causes a lot of functional impairment. So for them, I must say that EGP 761 it has worked quite well, not only in terms of the cognition, but also what we term as behavioral activation. So something that we call as negative symptoms, or an individual is apathetic, lethargic, they're not willing to do much. So that's one domain. The other aspect is when we talk about behavioral and psychological symptoms of dementia, PTSD, in that apathy is something which we commonly struggle with. We don't have much medications approved for that. And for individuals who become apathetic, the family members, in fact, complain and they suffer a lot. So I would say that in my practice and experience, again, this molecule has worked well. Especially, we have got results for as early as 3 to 4 weeks in terms of the emotional balance. With respect to MCI and vascular, or for all practical purposes, most are mixed because there is a mixed pathology. There has been very encouraging results. We are also currently in a process of a trial, very early phase that we have started with individuals with mild cognitive impairment. And again, like mostly in non-Alzheimer's dementias, especially vascular, I have also tried this in few individuals with frontotemporal dementia, especially the semantic variant. And in the early stages, as Dr. Agarwal mentioned some time back, the psychobehavioral symptoms have actually responded pretty well, especially the nighttime behaviors and agitation. With respect to bleeding risk, yes, this is another thing that we commonly discuss, even though I have found it in less than 5% of the population that I have used. I would say that if used preferably after evenings, there is an issue with sleep. And many times individuals have complained of nausea, quite significant nausea and gastric disturbance, especially if not taken after food. And the other thing which I often come across is drug-drug interactions, especially individuals taking SNRIs like venlafaxine and sometimes fluoxetine in our patients. But all in all, I would say that it's fairly well tolerated, and definitely it's a very useful drug in our armatorium, especially in cases where individuals are early in the stage, as well as when they have significant behavioral issues, especially apathy. That would be my take.
Okay, so how long have you used this drug in your patients? How long? What is the maximum duration?
Uh, I have patients probably who have been on this medication for now roughly a couple of years,
Okay, okay,
and I
okay.
have used usually in a bit higher doses, so that is roughly around
Well,
120 to 240.
yeah, we'll come to that to Dr. Martin. I think this is an important question that I feel that in India, especially, I find many patients are not taking the adequate dose of 240 milligram per day, right? So there has been some concern about it, and I find that even when we start with 240, some people then drop down to 120, and then they probably lose out the effect. So what's your take on that? The dose, 240 milligrams per day.
Well, the placebo-controlled trials were quite clear on that. So with a 120 milligram daily dose, there was no clear effect as compared to placebo. But with a 240 milligram dose per day, we have seen all the effects I have presented. So we clearly recommend a daily dose of 240 milligram, and this dose was well tolerated in clinical trials.
Right. So this must be emphasized to all the participants, listeners, that you should give the right kind of doses. Otherwise, you will not get the effect that you want. Now, I'm coming to Dr. Konda. Now, Dr. Konda, in neurology parlance, in neurology circuits, when I go to the meetings and talk about this product, many people will say, no, the evidence is not that robust. I mean, it is just one of those, supplement kind of a thing. And it probably doesn't stand that much with say, donepezil or rivastigmine. So, what's your take on that? Do you think that this drug is just an add-on? It can be given in early stage of MCI as a single drug, or usually you give it as a combination with other drugs. What's your take on that?
Thank you, sir. Thank you, Martin. That's a great talk. In fact, it's a comprehensive talk, covered all the things. I've been using this molecule since last 2.5 years, but I'm using as a combination drug only, along with the donepezil or rivastigmine or memantine only. But I am experiencing good results, promising results with the patients. Especially, I have a bunch of patients, more than 20, 25 elderly patients, all are more than 70 years. Many of them are vascular cognitive decline and even early Alzheimer's also, even MCA patients. They are doing very well. And I can say that their cognitive decline is standstill after starting this medication. And I am examining frequently these patients in the evenings leisurely, and I am taking proper time also for these kind of patients. I am running these cognitive patients in the evening, especially after 5 to 8 p.m. like that, so that I am having adequate time to analyze even, and I am seeing good results, especially there, as one of the speakers mentioned, that apathy is improved very well, and few of the patients I am asking their visual spatial function. Previously, they were used to confuse in their colony or their home, but they are improved and they are able to en route to their home as previously normally. So I am definitely it is good, even though there are not adequate studies. But if we give adequate dose, especially like 120 to 240, I think still it is a good option. Uh, I think even the monoclonal antibodies also even approved even in mild disease only, not for moderate or severe disease. I think no drug will work for moderate or severe disease in Alzheimer's after losing so many synapses or so many cells, acetylcholine producing cells. I think it's a promising drug. In the near future, this pure extract of EGB 761 may be approved as first line drug.
Right. So I think Dr. Martin has shown the evidence. Many of the agencies have shown it as a good evidence, and they're placed quite high up. And he said that he likes one of those evidence statements pretty well. But coming to another important point about impurities that Dr. Martin suggested and showed, and I also mentioned in my initial, talk, that impurities are very important in trans weight products. And what do you think about the existing other molecules of ginkgo biloba and the impurities there in the glycolic acid content? Are they being monitored that well, or and EGV has a distinct edge because you have consistently kept that level pretty low to avoid the side effects? Dr. Martin, please.
So the quality or the purity of ginkgo biloba extracts really depends on the manufacturer, but also on the region where the product is brought onto the market. For extracts that are marketed in Europe, where the ginkgo extracts are considered drugs and are supervised by the drug regulatory authorities, there's in general, quite good quality. For example, the ginkgolic acids I have mentioned, they are low in all of the ginkgo extracts on the European markets that are registered as drugs and are marketed as drugs. Because if it's a drug, the whole manufacturing process is subject to inspection, and we and all the other manufacturers manufacturing drugs get regular inspections from the authorities who check in every detail that we produce the product exactly as it has been approved. So for the drugs, there is in general quite a good quality. And even so, if we look at constituents that have not yet received so much attention, we can find significant differences. For example, recently we looked at proanthocyanidins, a group of compounds making up about 7% of the ginkgo extract that is not regulated in Europe by the authorities, and we have found that our product is always stable around the 7%. And for the other drug manufacturers, there was a large variation. In many, even of the ginkgo extracts on the market as drugs, there were no proanthocyanidins available. So even within this regulated group of ginkgo biloba drug extract, there is variability.
Right.
If you look to the food supplement market, and in many countries, ginkgo extracts are available as food supplements.
Correct.
There is no overview from authorities, no inspection, no quality control, and we have looked into many of those extracts. Some of them are good, some of them don't even contain ginkgo, and nobody knows because there is no control. So you should never trust herbal extracts, especially ginkgo extracts that are marketed as food supplements.
You're right. And I think this is important because I think that because the market is flooded with a lot of these supplements, and a lot of companies are suggesting this, these drugs. So therefore, I think one has to be careful in what you prescribe and what you give to the patients, and you have to be sure about its quality. So coming back to Dr. Arya, that with these patients come to you and ask for help, the family is perplexed that the patient is deteriorating cognitively, and also there are a lot of psychobehavioral symptoms that they have to deal with. So when you prescribe this drug, what do you tell to them? I mean, what kind of expectations do they have, and how you allay their fears and concerns?
Patients coming with MCI, the mild cognitive disorder, or the impairment, therein the activities of daily functioning are not affected to a large extent. So people are concerned, keeping in mind the benign senescent forgetfulness, as well as a person developing the normal cognitive decline which takes place over age, and we qualify as a diagnosis of mild cognitive impairment. We explain them that this is a herbal supplement, and it is a product which has studies to prove that it causes neurogenesis, and it will further prevent the progression of dementia and to Alzheimer's, wherein the person will have incapacitating disability in all other activities of daily functioning. So the patients are quite comfortable in understanding this, and the cost does remain a concern, but I am able to convince them to take at least 240 milligrams, and patient do show response on this on a BD dose of EGB 71. Whereas patients with Alzheimer's dementia and vascular dementia, they have to be combined with donepezil and rivastigmine. And I have seen remarkable improvement in patients with these when I do the MMSC scores with this. Also, I don't know whether I'm okay on this, but a combination does work for moderate to severe Alzheimer's dementia, wherein we have acetylcholinesterase inhibitors as well as EGB 71.
Right. So you find it, I mean, generally not a difficult task to convince the patients and the caregivers to, take
Yeah.
up this drug, because some of them nowadays are slightly wary also of, there are two sides. One group is very wary of taking allopathic medication because they fear that there will be a lot of side effects. And so they want some, indigenous or plant-based products. And some people are very, fearful about taking these plant-based products because, as Dr. Martin said, that there might not be good quality control, and there might be problems with that. So, but you don't find that. That's a very reassuring thing. Dr. Vinay, now the question comes that seeing the Indian population, Indian psyche in mind, right? Where generally the cognitive decline at an age of say 70 plus is generally taken as a normal phenomenon, you know and the patient coming to you, many a times they come to a different problem like headache, arthritis, or back pain, and then the relatives will also say, doctor, he's started forgetting things, and so early stage of MCI or early dementia. So in these patients, do you consider that a drug would be useful, and have you given to this kind of patient?
Yeah, I think I would like to put my point by discussing two cases which I have seen the result. Like one of the like these two patients are having difficulty in dual tasking. Like, so they were having some other disease. They came to me that they were having some kind of problem in dual tasking. One of the patient, when he used to walk, and he used to walk with some of his friend, if he starts talking, he gets imbalance. So that patient was put on this EGB 761 240 milligrams per day. And the other patient, when he used to walk and he used to talk one of his friend, he used to forget what he was talking earlier. Okay, so the second patient, that patient also came with another problem. So the family members and the patient himself, they narrated this story. So both these patients were kept on EGB 761 240 milligram per day, and to my surprise, in 2 months they were much better, and there was no difficulty in making a balance, and he was not forgetting. So, if a patient is coming with other neurological problems and the neurocognitive problems are significant, they always come into picture while discussing these problems. And if these problems are really disturbing for a patient, they are really receptive to listen what you say, and they are receptive, and they are compliant to take medication EGB 761. So through these two examples, I am very much convinced, and I am able to convince my patients by giving these two examples that it really works. But you have to keep patient. Sometimes it may take few months, but it definitely works according to me. I try to convince them that way.
Yeah, that's good. I think that that's a common scenario faced by both psychiatrists and neurologists, that patients would come with the kind of a different complaint, but then later you will find on a consultation that they are having some degree of cognitive issues as well. Dr. Martin, one concern though, in the prescription analysis that you have shown, in Germany, from Germany, the two studies you have shown from Germany, in that the number of patients who were receiving EGB 761 were pretty low. I mean, there were about 170, 77 patients, something like that, compared to about 3,000 plus or 4,000 patients on the other group. So, what do you make out of it? I mean, the physicians in Germany are not very keen to prescribe this medication.
One of the reasons is that in Germany, the cholinesterase inhibitors are extremely expensive. They are around one cent per day, or so daily treatment costs. That is far below what we can manage as production costs for a tablet of Tebocan. So one important aspects for the limited usage of the compound of Germany certainly is the price we have to take because of all the quality insurance measures we make, and because production of a herbal extract is associated
So
with
it's not
some
insured. It
costs.
doesn't come under insurance, or state doesn't give it.
Yes, it is reimbursed, but physicians are limited in the amount of medication they can prescribe. So they typically select the cheapest ones.
Okay, okay. And what is your take on? I mean, can you give us some idea about how this product is doing in China? Because originally the ginkgo biloba product is believed to be originated in China. So, and they have their indigenous various types of ginkgo biloba preparations, I'm told. So, can you give us a kind of your figures in the China so that we can get an idea that how effective or how popular the drug is in the China?
So in China, ginkgo medication is very popular, is very widely used. We are happy that our product manufactured in Germany is also used in China. There are plenty of Chinese manufacturers of ginkgo medications, but the usage is somewhat different. The main indication is post-stroke cognitive impairment or even treatment of acute stroke. And in China, there's also an intravenous application form available. So typically, patients are started with intravenous treatment within the hospital, and then they are switched to oral treatment when they leave the hospital. And it's also used in some other indications we are not familiar with in Europe, such as glaucoma or diabetic retinopathy or diabetic neuropathy. This is very typical for China, and there are quite interesting Chinese studies with ginkgo, with many ginkgo preparations in these indications.
Correct, correct. So, Dr. Debanjan, now can you tell us about that? Among the neuropsychiatric manifestations, you said apathy is one particular thing, but I think that is slightly a later kind of a manifestation. The first manifestation, I think, is that when the patient is still retaining the cognitive element and understanding that he is making mistakes, he's forgetting things, he's forgetting the way to home and getting very irritated, agitated. There are mood changes, lability of mood. There are a lot of affect changes. So, do you think the drug works there as well?
Yeah, thank you, Dr. Chaudhary. I think that's a very, very pertinent question. In fact, most of the patients who do consult us will definitely not be for apathy, but for the other round of the spectrum. When there are individuals who get agitated, especially we have psychotic symptoms in some of our patients with Alzheimer's, who also have BPST, and definitely nighttime issues, uh, craving for carbohydrates or sugars, and frontal symptoms, especially in those who have frontal predominant dementia. It can be FTD, or it can be the frontal subtype, or sometimes even in Alzheimer's itself. So I have seen that for the individuals who do have significant agitation, and especially issues with altered sleep wake cycle, a lot of food craving, problems with disinhibition or sexually inappropriate behavior, for them, between doses of 120 to 240, of course, trying to ensure that their insomnia doesn't get increased, because sometimes late evening dosing I have seen can lead to sleep disturbances. Uh, Dr. Martin will be able to tell us better. But then they do really help with this behavioral complaints. And as one of us were mentioning about the visuospatial area, so apart from that, I would also say that I have used in a few individuals with posterior cortical variant of Alzheimer's. And the good thing is, even though it's still in the form of a case series, we are waiting for more individuals to be tested. But the depth perception and the number of falls, both in posterior cortical variant as well as in some individuals with Parkinson's plus. I don't know exactly the mechanism. Of course, I was also doing the literature search, but in the initial phases, definitely there has been an improvement. Besides behavioral symptoms, I think these gains are very important, since we do not have really other medications to target these. And uh, what you were mentioning last time, I think dosing is a big issue. Many of the patients who say that they haven't got any visible effects are either with 60 OD or a 120 dosing, and there have been multiple manufacturing syrup formulation, oral formulations with this dosing. So unless the person is put on the dose that has been quite evidence based in trials, I would say that there is always an option of trying this molecule EGB761 in individuals, both for cognitive as well as for psychobehavioral issues in dementia.
Correct. Fine. That's a very pretty good answer, I think. Dr. Martin, what about your night dosing problem with the sleep problem? Is there any data for that?
No data to my knowledge. We haven't seen insomnia as a side effect in clinical trials, but in clinical trials, the dosing was typically in the morning. We have heard multiple times the same that the experts here report that in some patients, if you dose it as the evening, they can report insomnia. So the general recommendation would be to have a morning dosing of the product. And single daily dosing is absolutely sufficient. We have done clinical trials with twice daily 120 milligram and with once daily 240 milligram, and there was absolutely no difference in efficacy. So we would recommend 240 milligram in the morning. And this is well tolerated. We have also studied in small clinical trials, higher doses up to 400, 600 milligram a day. Certainly, we as a manufacturer cannot recommend any higher dose than the approved one, but in those clinical trials, also the higher doses were well tolerated.
Right. So now coming back to Dr. Konda, I think one issue that always comes, in our patients, that you start this drug, they get some initial benefit, so-called because they are expectant, and you have explained to them that this is a new drug, this helps, and they probably see some effect up to a month or 2 months, and then it plateaus, and then it becomes a little difficult for you to convince them to take it on, to have kind of a onward benefit, as shown by Dr. Martin, that your progression is also delayed, right? So how do you go? What's your take on this? I mean, do you face such problems in your patients, that the patients start become impatient after after a while, and then would say that, okay, doctor, give me something else, I'm not finding that, after the initial honeymoon period?
Yeah, this is the regular problems, or in fact, the disease progression sometimes maybe corresponding factor also. Many of the times, I'll enhance the dose and I'll convince that it will work. And many of the times, I'll tell that do some puzzles or some kind of activity with the children, with grandchildren, so that it will enhance the synaptic plasticity will be enhanced. So this is a regular problem I think encountered by every practitioner with such kind of patients. But few may accept, few may not accept. But I'll enhance the dose for their satisfaction, and I'll see.
Right. Okay.
Dr.
So
Debashish.
now,
Yeah, yeah, yeah. Can I ask question? Yeah, I have a
yeah,
query.
yeah,
Yeah,
yeah, sure.
yeah. My query is like to all the panelists and to Dr. Martin. Like my experience has been that with EGB 761, the psycho-behavioral part, the response is earlier in comparison to cognitive improvement part. So why there is a time lag? Or do you agree with it? Or rest of the panelists agree with it? What is their experience? And if it is theirs, is the same their experience, why there is a time lag between these two effects? Is there any data to support it that behavioral part improves better earlier than comparison to cognition part?
Dr. Martin, please.
So thank you, Dr. Agrawal, for sharing this experience. To be honest, this is new to me. We have not seen this in clinical trials because we have not looked for it. We have analyzed patients in clinical trials after 12 weeks, after 24 weeks. So I'm afraid we have missed this observation that you have made in clinical practice. So I'm sorry, I cannot add any data to support this information, but this is an important observation, important information. Thanks for sharing it. Concerning of the modes of action, so this is difficult indeed, because the compound has so many different mode of actions. There will be so many adaptation in the brain based off some of the effects. So it's very difficult to interpret which effect will result in which clinical benefit. In animal models measuring neurotransmitter changes, we have seen effects not after a first dose. After first dose, there were no effect. We've seen an effect after 1 to 2 weeks on neurotransmitters, and we could not explain why it took 1 or 2 weeks. It was just an observation. After 1 to 2 weeks, there is a increase in dopamine in the synaptic cleft and a bit of an increase in acetylcholine in the synaptic cleft. And obviously, in animal models, it took some time.
Correct.
Thank you.
Debanjan, you wanted to say something. Debanjan?
Yeah, hi. No, I think it's in the same lines as I was in what we were discussing and what Dr. Martin just mentioned. I was going through the literature and also that presented right now. I don't think there is a very clear timeline establishment between the improvement of behavioral symptoms and cognitive symptoms. In my experience, with roughly around 50 odd patients, I'd say that uh, I didn't find that the behavioral symptoms improved more compared to cognitive, but probably one of the reasons can be that sometimes minor changes in cognition may not be detected unless we really use the systematized, standardized scales to understand. Of course, the quality of life improvement or the functionality improvement will come to the notice uh, faster. And in terms of behavior, let's say somebody who's significantly agitated or somebody who is having a lot of wandering at night times, post evening, worsening of their behavioral symptoms, typically sundowning. For them, I think the change comes to notice clinically faster in terms of the NPI that we use, neuropsychiatric inventory. The caregiver distress and quality of life improves faster. So probably that may be one of the hypothesized reasons why the change in psychobehavioral symptoms comes to our notice early. But I sincerely think that this is a very important area of further work or trials to see that if there is a timeline, and in case if there is a timeline, if we can start it early enough so that we can prevent the behavioral and psychological symptoms from progressing. If the improvement happens in both the domains, that's a total win-win situation.
Yeah, you are absolutely right. I think that, you know, when, behavior overshadows cognition, actually. And when the behavior improves, the patient's relatives are much comfortable. They are not so much concerned initially about the cognition part. They are more concerned about the behavior part. So when both these things come together, if the patient becomes sociable, patient doesn't have mood swings, agitation goes off, he has developed a normal rhythm of sleep. So patients and the relatives are much, much better, even though he might not be able to perform the higher
Yeah.
cognitive tasks at that
No,
point of
just to add something, in India, at least, I'm sure all of us will agree on this, that forgetfulness is often considered to be something that is normalized with age. So
That's what I
behavioral
said.
change,
Yeah.
yeah, behavioral change is something that brings to healthcare much faster, and that's the main concern. So yeah,
Yeah.
that brings us to the point.
So that probably reflects and shines through, and probably the cognition takes a little backseat and then it improves over a period of time. Now, Dr. Martin, one thing important thing I want to ask you this regarding the Indian study. So when I discussed the study with my colleagues, neurology colleagues, they many of them actually say it's an open level study, and your the investigators are seeing, they are giving the drug, they know that the patients are there, and then they're assessing. So there might be a lot of bias into the study. So I have some points for that, but what's your take on that, about that study, the Indian study? Because there's a large number. I mean, I think 150 plus people, so persons with the disease. So what are the major points you should think that they are worthwhile in that paper, the Indian study?
From the Indian study, I was very impressed by the rating, the global rating of the physicians. Those physicians treating the patients and knowing them for some time and having plenty of experience with patients with mild to moderate dementia. And as I've shown you, not the first 4 to 8 weeks, but after 12 to 18 weeks, more than 50% of patients were rated as very much improved or much improved. And so for experienced clinicians who have treated patients for years and have seen how they decline, so certainly they also have seen some variability in symptoms, but to give a rating of much improved to very much improved to such a patient is really a significant signal and is far beyond what I would expect if with an inactive treatment. So I was most impressed by the ratings the physician gave to those patients.
Yeah, yeah. So that is a very important point, and I think there is a possibility that that might be a little bit influenced by the Indian scenario by Indian patients, because the global data, whatever you had published earlier, is showing that response rate to about 30 to 35%. But India, we had got a little higher than what we achieved globally. So that is number one. Number two is one has to remember that this was a multicentric trial. So there are individual specialists across India, 8 centers. So obviously that bias chance is decreased because you have got multicentric trial, even though it's open level. So that is another point you should want to take into account. The third thing is this, that there has been it has been very structured study, and we use a lot of instruments to actually document the changes, including the trail making test, the behave scores, the AD scores. So it is very structured, and the methods were quite robust. So I think, therefore, to suggest that Indian patients are benefited because of this drug through this study, the phase 4 study or an open level study, is significant. I think that gives a general idea, which is matching with the observations of our esteemed panelists, that the drug does help, and it's useful for many of these Indian patients. So I think we have covered most of the ground, Dr. Martin. Anything else you would like to say as a final comment?
Not from my side. I think there is another question from Dr. Banerjee.
Yeah, Dr.
Yeah.
Banerjee?
Hi, Dr. Chowdhury. Can I ask it now?
Yeah, sure.
Yeah. So, Dr. Martin, just one final question. Uh, kind of, thinking of all the discussions that we had so far, and especially since nowadays we talk a lot about the pre-dementia pathogenesis state, since we roughly consider that the pathogenesis process starts pretty early, and the earlier we can intervene, the best it is. So, in your vast experience in the studies and trials, if I were to ask you that, if I am to prescribe EGB 761 to somebody who has come to me, let's say, be it in the MCI state, in the mild dementia state, what would be, and FDA doesn't really recommend a medication for MCI as of yet. So, if somebody is coming to me, at what time point, considering that the person is not having behavioral issues only in terms of neurocognitive impairment, at what time point would you think it is best to initiate this medication and at what dose?
Thank you for this important question from a clinical point of view. So I would really rely on what is in the Indian guideline now that recommends to initiate EGB 761 at the stage of mild cognitive impairment, but certainly not as the only measure, but as part of a multi-component approach to try to improve and to stabilize mental health of the patients, certainly focusing on cardiovascular risk factors, on vitamins, on hearing and vision impairment, and then all the other factors that might contribute to further cognitive decline. So the recommendation would be to start at mild cognitive impairment. There was also an interesting analysis recently published from the Turkish side I've mentioned. They exactly looked into that point. Where did they see the most benefit from adding EGB 761 to other treatment modalities? And their impression from several hundred, from nearly 1,000 patients they analyzed, was the earlier they started the treatment, the more benefits they did observe in their database. So I would recommend to start it as a mild cognitive impairment state.
So,
and certainly, as I mentioned earlier, always at the dose of 240 milligrams. So there isn't good data to support a lower dose.
right.
Thank
And
you.
Dr. Martin,
Thank you,
as an
Dr.
extension to this question is this: are you planning any study in which you will say you will look at the early biomarkers of, say, Alzheimer's, and categorize not just based on clinical MCI criteria, but early biomarkers for Alzheimer's, and you then start. Are you planning any study of EGB 761 on that ground?
So not we as a company, but we know that some dementia experts are currently running such trials. So we are aware of one trial in Israel, in Jerusalem, that is currently underway, and another trial in Spain has been completed but has not yet been published, exactly looking for effects on biomarkers in patients with mild cognitive impairments. This was a randomized controlled trial with some very interesting results, not specifically on traditional Alzheimer biomarkers we are used to, but to other biomarkers we need to understand. Apparently, there is a network of effects within the brain that might underlie the benefits. So we are looking forward to see data on biomarkers soon.
Right. That is a great news, and I think we will learn. And I think you will continue to explore the possibility of using this drug and expand. At least as Debanjan is suggesting, the timeline. As early as possible. And besides the clinical clues, if we have something to latch on to it, right? So like biomarkers, imaging studies, or you know amyloid PET, of course, is a different ballgame altogether. But anything more tangible in addition to the clinical clues, then that will be very nice. So I think we have covered quite a lot of ground today, and I think at the end of this thing, I will just request my panelists to give just one sentence message to the listeners who have joined about this drug. Dr. Vinay?
Yeah, I will say we have a medicine now which doesn't cause problem. It's a very well tolerable. There is not much of a drug interactions. We can start in patients with suspected MCI at the earliest possible.
Okay, Dr. Konda?
Yeah, sir. I also agree with Vinay, sir, and I think we can use full dose. I think 240 mg at least.
Right. So that is dose is important. Debanjan?
Yeah, thank you. I would say that we are normally very skeptical about nutraceuticals as it comes, but here we have a clinically effective molecule, evidence-based, something which can target the neurocognitive as well as the neurobehavioral aspects. So I would definitely say to increase its use, because the more data we have, especially in the Indian or South Asian database, the more will we know about all the things that we discussed today.
Okay. Dr. Arya?
Sir, I would say that we can prescribe this drug in all cases of mild cognitive disorder as well as Alzheimer's and severe Alzheimer's also. And we do need more efficacy to prescribe it in other psychiatric disorders, which are important for us, like bipolars and schizophrenia, which are chronic psychiatric disorders. And eventually, the neurocognitive impairment, which is very early in these disorders, so which also helps us in bringing back the person to remission. So it's a safe molecule with least drug interactions, and I think it will do wonders for people with cognitive decline in these disorders.
Okay, thank you so much. So I thank all my panelist friends and, of course, Professor Martin for an excellent lecture. And I think we had covered quite a lot of ground on this molecule. And now I think most of you are at least knowing the scientific evidence for the role of EGP 761. And I hand over the proceedings to the host, Simran, for conclusion.
Thank you so much, Dr. Chaudhary, for amazingly moderating this panel discussion, and to all the esteemed speakers for leading this vital discussion on neurocognitive health and therapeutic promise of EGP 761. And special thank you to Dr. Martin Burkat for its insightful presentation and our expert panel for sharing clinical wisdom that truly enhances our understanding. And we are grateful to Schwabe, India, for supporting this important initiative, and to each of you in this audience for your time and engagement. On behalf of Voice of Healthcare, thank you so much for being part of this meaningful dialogue. Until next time, stay informed and stay inspired. Thank you so much to all the
Thank you.
panelists.
Thank you. Good
Thank
night.
you.
Thank you.
Thank you. Bye bye. Good night.
Thank you.
Good night.
Good night.